So today we have Danna Markson. She's the founder and CEO of Mind Soother Therapy Center here in Livingston, actually right in my building. Welcome,
Thank
Danna.
you. Happy to be here.
I've been wanting to have you on for a while now. I think it's really important to talk about um, therapy and what you do. So I'm going to have you tell everybody what your practice does and what you specialize
Yeah,
in.
great. Thank you. So I've been a licensed clinical social worker myself for 30 years. I've had several specialties. One has been teens and families, so I'm a family systems therapist. And the other is eating disorders. So since day one, I've really had a focus on helping people with disordered eating, with diagnosed eating disorders, and body image, body dysmorphia. And over the years, I've worked in every level of care. So I've worked at Overlook, I worked at Princeton House, I worked at Carrier Clinic, I worked in the outpatient programs there, really helping people with intensive eating issues or even just mild eating issues sort of develop healthier coping strategies and relationship with their self and their body. And about 12 years ago, I opened Mind Soother Therapy Center in this building in Livingston because we had too many referrals for one person. I was seeing so many people. I was running eating disorder groups and DBT groups. So I brought in a couple of other therapists at the time. And now we're 18 therapists. And we work with kids,
Wow.
teens, and families. And then four of us have a specialty in eating disorders. And we're DBT informed therapists, which really means that we help clients develop coping strategies in addition to talking and active listening, we help people learn some new strategies for coping. So that's what we do. We also run a lot of groups. We run 6 weekly groups in our practice right now.
So is DBT therapy used for eating disorder?
Yeah, that's a great question, actually. So for bulimia or binge eating, we use DBT, which stands for Dialectical Behavior Therapy, because those are for people that are for under controlled behaviors. So for bulimia or binge eating, under controlled. We use something called RODBT, which is radically open DBT for people with restrictive eating disorders because they're more over controlled. So there's a little bit of a difference in the protocol. But yeah, so I've run many DBT skills groups for people with binge eating disorder and bulimia because overeating is a coping strategy for stress, anxiety, depression. And so it's really helping to create new coping mechanisms instead of using food to soothe or getting stuck in an addictive cycle of eating compulsions like that. So we use DBT a lot in helping to manage under control.
Right. And I was going to bring that up because today I know I can talk to you for hours about all different things, but today I wanted to focus more on eating disorders. Um, I could be wrong, but when people think of eating disorders, they always think of it as losing weight,
Right.
as the disorder,
Yeah.
right? Instead of we look at people that are gaining weight and you hear, well, they need to embrace their body image, good for them, that kind of talk, where really to me it's an eating
Yeah.
disorder. Is that right in the thinking?
Well, it's a little more complicated than that. So in a diagnosis, we use something called the DSM, which is the Diagnostic Statistical Manual, to actually give clients a diagnosis. So it's not just like, okay, that's what you're telling me. Okay, you have this diagnosis. They actually have to meet criteria. And yes, in restrictive eating disorders like anorexia, weight loss or staying at a percentage under your ideal body weight are things that we look for in a diagnosis. But that doesn't necessarily mean that you don't have disordered eating or an eating disorder. So, weight really has very little to do with a diagnosis of an eating disorder, especially in the case of bulimia or binge eating disorder. You could be underweight, you could be within normal limits or average limits, or you could be overweight. We take that all into account, but it's just a super small piece. The way that we work at MindSoother is we look behaviorally. How are you using food in your life? Is it for nourishment or sustainment? Is it for enjoyment? Is it a stress mechanism? Is it a compulsion? And so we help people identify those patterns. It's not really about your body size necessarily. We use a health at every size approach. I don't know if you ever heard of that, but it's really basically like as
Mm,
long as you're nourishing your body in a particular way that sustains you and gives you energy, and it's not being used for soothing or for anger management or for stress reduction. Your body size, you can be super healthy and be overweight according to, BMI or your doctor's scale. So we really look at the whole person.
right. I get it, and I am not a therapist, but I get that question a lot of times from parents, moms, and I'm hoping you can help. And when they see their daughters gaining some weight and they just don't know how to address
Hmm.
it, what are some helpful hints that you can give a mom in bringing up or the conversation with their children?
Yeah, and that's a trick question. There's no answer to that question that's a good answer. It really depends case by case. If your teen is going through puberty, your body is developing, it makes sense that you're gaining weight, right? You have hormones and your body's
Right.
changing. We don't recommend that parents bring it up necessarily, unless it's like an elaborate weight gain or it's happening very soon or the doctor's concerned about something. We don't want people to body shame their children. We want kids to feel
Exactly.
very comfortable in their own bodies, or even partner shaming. We've seen that before where a spouse will say to their partner, "Hey, you look like you put on a few," right? We really try to work with the whole family system to look at patterns of behavior. So, for example, if a kid is gaining weight because in the middle of their night they're waking up and they're eating 25 Oreos, that's different than the kid used to do field hockey and now is a little more sedentary and so gaining a little bit of weight because less activity. Those two things are very different. We would have the parent sort of address the pattern of behavior. Hey, Susie, I noticed that in the middle of the night, you're up and you might be snacking. Is everything okay? Not about the weight gain associated with it, but more about the pattern of behavior. Are you sleeping okay? Is there anything that you want to talk about?
Right. And you always have to seek professional help, I believe, if it's to the point where you don't really know what to do and you don't know how to address it.
Absolutely.
Because you can make things a lot worse. I've heard things come out of people's mouths that it's just,
It happens all the time. Especially where we see parents who are very restrictive in their own eating and are very careful about managing their own intake and expect the same for their kids. And the expectation is you don't snack between meals or, dessert comes only after dinner type of thing. And sometimes those messages don't work for their children, right? And it's too much control. And kids, especially teens, like to act out against power and control, right? So they'll go to do it just to piss their parents off. And now we have a power struggle on our hands around food. And we really try to help parents and families understand the cycle of behavior, the messages that you're giving about body size, weight, food. It's really important.
no, it really is, and it's a hard topic. It's a really hard topic, especially nowadays with social media
Yeah.
and filters that are. I think we lost Chris. Filters that are on social media and the girls and their. I mean, are you finding that to be an issue right now in today's world?
Um, I noticed a huge shift about 10 years ago. I was talking to Tessa, my associate, the other day about the difference. When we first started together, social media was kind of a thing, but there was no Instagram and Facebook was like a baby and, there was no TikTok or Snapchat back then. And that's when we started really noticing it, when that became a little more prominent and, Instagram and Snapchat and people are sending pictures of each other without words, just could be words or not, right? Or sort of FOMO, like, look how pretty this one looks in her prom dress with these people. And yes, so we definitely see that people are more mindful about their image, but I'm not seeing it necessarily any more this year than 2 years ago or 3 years ago. I think there's been an evolution since, Facebook, Instagram, all of these apps Everyone's just more visible to each other all the time.
I also think too with TikTok now, and Dan, I'm sure you know that. I mean, there's some filters that completely change someone's face
Yes,
to make it more
yes.
chiseled, more model-like. Where it's cool to see though too, because there are models coming out and saying, this is not what we look like. But for some girls that maybe don't
Hmm.
know that it's a filter, it can be really detrimental.
Yeah, absolutely. People are striving to look a certain way, right? And it might not be possible, right? I can't grow any more than I already am. I've achieved my full height, and everyone has different body types, different genes, different levels of activity, right? How much they're willing to exercise, how fast their metabolism is, what are their genetics. So not everyone's destined to look the same. I think that's a pretty cool thing. Especially though teens compare themselves a lot to each other. That's just sort of natural for that age and that developmental stage. And I think it's really difficult for them to not say, well, I look worse than, or she looks better than, or they didn't invite me to, or I'm a loser. What we try to do with people is to help them recognize reality and accept reality, right? Like I have curly hair. If I want straight hair, I have to do something to it. It just doesn't naturally straight. And it took me a while as a kid in particular to embrace it. I'm just kind of like, oh, I wish I had straight hair. It would be so nice, right? And I don't. So what can I do to love the hair that I have or change it, problem solve it? But to get stuck and feeling bad about it isn't going to help anybody. So we really work towards self-acceptance of like who you are as a person, your mind, and your body.
It's true because years ago in high school, you had a handful of girls that you would compare yourselves to. There was nothing else,
Yeah.
right? Those are the girls in your grade. Now you have millions of girls that now you're comparing yourself. I mean, how do you? It's tough for an immature
Hmm.
child to sift through all of that. It's hard. It's not
and and,
easy.
and even just lifestyle too in general. Not just looks too, but people's lifestyles look 10 times better on social media compared to actual real life.
Yeah.
Going back to FOMO, and things of that nature.
I mean, if I'm going to post something, it's probably not going to be something that makes me look bad, right? It's
Hmm.
probably like an award
Exactly.
I won, or how great do I look in this dress, or look at this amazing mountain I'm standing in front, right?
Hmm.
No, it's absolutely true. And as adults, I mean, you see adults even give into the whole Facebook and I wish my life looked like that. And we're mature people, so you can imagine what it does really for
Yeah,
children.
definitely.
It's
Hmm.
tough. It's really tough. So you have 17
Yep.
therapists
Hmm.
working.
We do.
Is
I would love to take a few more if there's any therapists out there looking for a position. Yeah, our biggest issue right now is there's so many people that are seeking services, which is great. I love the fact that we've sort of normalized seeking help, mental health services at this point. There's so many clients and there's not enough therapists out there to service everybody. So, yeah, I think the pandemic really sort of isolated everybody. People needed connection and help at that time. And now, over the years, the stigma of mental health services has been reduced, which is wonderful, right?
that is really
Yeah,
great to
yeah,
hear. Yeah, because asking for help is not an
that's
easy thing.
correct.
But I
Well,
have to tell you, Dana, that anybody that I've known and that people have said that they have seen you. So it's not all therapists. They all rave
Oh, that's
about
so
you.
nice. Thank you so much. I appreciate that feedback.
They, yes, they all rave about you. So anybody out there who is looking, now we need to put more on your
Thank
plate,
you.
Dana, but you're an outstanding
Thank
therapist.
you.
Outstanding.
I think what makes me different is I'm very realistic about the process, and I feel compassion for every human. I also challenge people's narrative. I'm not afraid to say, "Hey, listen, Pauline, I don't know if that line of thinking is really helping you. Do you have some space to change that, or can you look at that differently?" I listen to you and I hear where you're coming from, and I'm not afraid to lean in and challenge it in a very compassionate way. And I think that's a sign of a good therapist. Somebody who can say, I don't know, what's another way you could see that? Or how is that behavior helping you? Right. And especially in the case of an eating disorder, because eating disorders can be very difficult to manage. Most anorexics don't want to change. They'll come into the office like only because their parent or their partner or their boss said you can't work here anymore, right? Or their doctor, or they had a heart incident, or their doctor said you have to. That's typically why people with restrictive eating disorders come. People with bulimia and binge eating come for other reasons. So when we get a client with a restrictive eating disorder coming into our office, they don't necessarily want to gain weight or shift their behavior, right? And so telling people that they do have a choice and they're holding their lives still in this moment. You can't grow as a person if you're not getting nourished. Your brain can't function well. You're putting yourself at medical risk. So really helping people understand, like, yeah, I'm really hearing you, how hard this is for you, and you're robbing yourself of opportunity for the future. So how can we work together so that we sort of expect 2 steps forward, 1 step back in the world of eating disorder therapy, because it's so hard to break out of that cycle.
It must be very difficult to deal with somebody who really doesn't want to change.
Yeah, yeah,
Is
I would say that's true for everybody. We get a lot of little 12-year-olds with anxiety, and they're getting something out of being anxious and not having to go to school, or parents accommodating their anxiety by buying them a treat if they do a thing, you know? It's one of our biggest struggles, and often we have to just acknowledge that we can't help people that don't want to change.
on the other side of that, do you know as a therapist if somebody is not being honest and telling you everything? Is there a way that, as a therapist, that you know that
Everybody,
and try to bring it out?
everybody.
Everybody?
So that's an interesting question. Um, I assume you're telling me the truth, and I always wonder if there's more, right? I'm not going to assume you're not telling me the truth, but what we do is we take what you're saying as truth and say there's likely more to this story, right?
Okay.
So yeah, there's no way, we're not mind readers. There's no way for me to know with any certainty. The only way would be is if you tell me one thing on a Tuesday and then the next Tuesday you tell me something different. As trained therapists, we might say, well, that's interesting because last Tuesday you said this, you know? But that's not our jobs. Our job is just to observe that and to reflect that back.
And I guess too, the more comfortable they feel with you and you start building a
Yes.
relationship, the more open they will become.
Yeah. And some people have what we call a very low shame tolerance. They're not willing to be vulnerable and open up. They can't handle shame. They can't handle feelings of inadequacy. And they feel like the therapist is going to judge them. And they can never break through that. As therapists, we're not judging. We look at ourselves as listeners who make observations and challenge assumptions. That's really what we're doing, and guide you towards your goals. I'm not here to go, oh, that's bad behavior. You should stop that. We're really not doing that. It would be very hard to be a therapist that was judgmental all the time. You know, it wouldn't feel good and it wouldn't help the client. So we really see ourselves as people who are actively listening. And if you can't handle the shame of telling us the truth, then you're not going to meet your goals most likely. And you'll probably drop out of therapy at some point because it's not going to serve you.
True. But is that something that then you would work on self-esteem? Does that kind of go hand in hand?
Yeah, it's sort of it all goes hand in hand. I think what happens is we have a toolbox. We are like contractors, right? We come to session with a big toolbox because I don't really know if I open
Interesting.
up
Yeah.
your wall, I don't know what I'm going to get behind there. So I have to have a wrench and a hammer and a saw and 25 things in my toolbox. As therapists, we have the same thing. And the first thing we have to do is listen to you, build rapport, like understand how the relationship is going to work. And then I might offer you a tool. So one of our associates was telling me a story the other day. She's like, keep trying to get Susie, who has anxiety. That's not her real name, but Susie, who has anxiety, to do square breathing, which is a type of breathing exercise. And she's like, I don't do breathing. Breathing doesn't work for me, which is actually really funny because we're all doing it and it does work. It keeps us alive, right? Breathing is scientifically proven to calm your central nervous system. So there's a method of breathing that you can actually reduce anxiety and stress and calm your central nervous system. And she's like, that doesn't work for me. I'm not doing that. Stop telling me that. So we come up against barriers like that all the time. Why does it serve Susie to challenge the therapist saying, do some breathing, right? So it's because of control. I don't want her telling me what to do. I don't want her being right about that. I don't need to put an effort into doing any exercises. I like being out of control. I like the way it feels in my body to be angry. There could be 100 different reasons. Our job as therapists is to say, hey, I notice when I give you a breathing exercise, you push back. What's going on? Right? And sort of reflect back and collaboratively problem solve, not to get people to understand anything about themselves. That's your job to understand yourself. I'm just like putting out there on a platter for you. So a really good therapist friend of mine just recently said, I look at myself as a server at a cocktail party. I walk around with a tray. You could take it or not. I'm presenting it to you. Here's some bruschetta and here's pigs in a blanket. Would you like one? But I'm giving it to you. This is what I have to offer you. You could take it or leave it. I thought that was a really cool
Right.
analogy.
It's a very cool analogy. A very cool analogy. And it's funny, I was talking to a friend of mine the other day about her therapist, and um, her therapist just seems to just always just agree and nod and shake her head. And I said to her, to me, a good therapist challenges you and asks you questions. And that's funny you said that, because I'm right then. That is
Well, it
true,
depends on
right?
what
You
you're
have to be
looking
challenged a
for.
little
If
bit.
you're not looking to change and you just want to be heard, that's a wonderful therapist, right? She hears me, she listens to me, she doesn't challenge me. I have a place to vent. I can get things off my chest. That's awesome. If she's trying to change a behavior, that's not going to help her, right?
It's
Yeah,
not going to help her.
right.
No. You might as well call your friend and just let her and vent to her,
Exactly.
and you're not going to get anywhere. You're not going to get the help you
Right.
need,
Exactly.
you know? And I'm sure you're seeing a lot more since COVID. Did we talk about? We didn't talk about that with COVID, with people in therapy. We just talked about
Oh,
people asking for
I
more help.
mean, in 2020, we had 6 therapists on our team, and last year we had 18. I mean, yeah, so the amount of need, the demand for therapeutic services has, quadrupled and just completely intensified. So, it's a blessing and a curse. I think people really needed it. There was a lot more mental health challenges. I think probably people needed it all along. But being home, so the thing is, they weren't at play practice and they weren't at soccer. And so all the things that would take up space and time that seemed more important than mental health work before, now they had time to do it. There was no excuses anymore. It's not that they didn't need mental health services before, but now they had time on their hands to actually get it. And it's interesting now in 2023, we're back to mostly in person at this point. We do some virtual, but we do a hybrid. People want in-person services. So now we're back to, well, she can't come because it's tech week for school or it's the soccer finals. And so we're back to that a little bit. But what we've learned really very clearly over the last few years is your mental health won't wait. It's not going to wait for you. It's going to go downhill if you don't take care of it now. It's like diabetes, right? If you don't manage your diabetes, you're going to have symptoms. Mental health is the same way. If
Right.
the doctor tells you you have a tumor and it's cancerous and I need to take it out and then you need chemo, you're not going to go, oh, I have tech week. I can't. No, sorry, I can't do my chemo. You're going to make every effort to make that happen. I feel like mental health is just as important as all of that, right? Because if you're depressed or you have anxiety or you have an active eating disorder, it's going to impact you physically as well as emotionally and your relationships and your ability to function. So we look at it, we take it just as seriously. I think it's even more important in some areas because if you can't function mentally well, it's going to impact all areas of your life.
It should be number one.
Yeah. I mean, we look at it like psychological, medical, physical, spiritual, emotional. We look at it all together and we want everyone to be working on all of those things at the same time. Like sleep, how you sleep is significantly important to your mental health. Your nourishment is significantly important to your mental health. We have a client, he's, I think he might, oh, it froze for a second.
Oh
Sorry.
yeah, froze. Okay.
So we have a client, I think he's around 7, and he will only eat white foods. Potatoes, white bread, I forgot what else. One other thing, like turkey. He'll only eat things that are white. And so the parents just keep giving him white foods, right? And so he has a problem on his hands because his sugar is out of whack and he keeps getting low blood sugar and feeling faint. But the parents refuse to tolerate his freakouts when it's time to eat peas or broccoli. They won't deal with it. So they keep just accommodating him and giving him white foods. And then the doctor keeps saying, got an issue on your hands. Oh, and by the way, the kid can't concentrate in school either because he's not properly nourished. Right. And so how we work is we would not work with a kid like that. We would work with those parents to talk
I was going to
about,
say the parents need
yeah,
it. Yeah.
hey, what's going on for you that you're giving in to Joey's demands? What does it feel like for you? Because you know in your heart, kid needs to eat salad or vegetables and fruit or meat. What's going on? Why are you giving in? Right. And so that's important. And how are we going to handle this together? Right. Like we have a certain goal. And the way that I tell people, I do this all the time, is again, if God forbid your kid had cancer, would you take no for an answer about chemotherapy? And they always say no. I'm like, this is no different. Your kid saying no to peas is no different than no to chemotherapy. So, what are we going to do to make that happen? How are we going to make that happen? Right. And like really supporting parents to help their kids get meet their goals, even if it's hard.
No, but I mean, that's supporting the parents, but that's also giving them a reality check, which they need.
Yeah.
I mean, I think it's brilliant the way you approach that.
Well, thank you. It's not always met with open-mindedness. You know, people are like, well, I'm bringing my kids to therapy. Well, we don't really believe, we don't work with any kids, even a 17-year-old, without working with the family system. They're living in a system, they're living in a unit. We don't necessarily demand that parents of 17-year-olds come to therapy, but we do have parent check-ins because I need to know, how do you think Susie's doing? What are some things that you would like Susie to work on? Because it's a unit, you know, and you have certain goals for your kids as well. The younger they are, the more involved we have the parents. Like we would never work with a 6, 7, or 8-year-old without doing family sessions because they need to continue the work at home. So they need to be empowered to do that.
And I'm sure it gives you a lot of insight of really what's going on if they're not being the most honest
Yeah.
with you in
Yes,
session.
definitely. We
Yeah.
like
No,
watching them play and
absolutely.
watching them interact together. Yeah.
What are some of the signs that parents can look for in their kids
For what?
when there's maybe a possible eating
Oh,
disorder or high anxiety or just signs that maybe people overlook?
yeah, good question. I think really the answer is any shift in or change in behavior or functioning. So if a kid used to be a little more peppy or a little more active, or now they're crying more, or they're complaining a lot, or they're only seeing negative. So anything that shifts, right, would be like an immediate sign something's up. So that would be like for anxiety or depression, right? Any kind of like they used to sleep through the night and now they're not, or they used to fall asleep well and now they can't, or they're sleeping more. Any sort of noticeable change for anxiety or depression. For eating disorders, it's a little more complicated. Often eating disorders start by kids skipping lunch at school, which their parents can't see. And often we'll hear from a school counselor or from the parents of a friend saying, I'm worried about Susie. She came to our house and she wasn't eating the snacks like the other kids. Or parents will call and say, you know, Susie disappears into the bathroom after every meal, or doctor said she's losing weight. So lots of different symptoms to look for. And you know your own kid. So we always trust parents' assessment on that. The first thing I would do is if you don't want to take them to a therapist, take them to your medical doctor and get a checkup. You know, get them on the scale, take your vital signs, maybe do some blood work. The other thing is, I always like parents to give the medical doctor a heads up about what to say and what not to say. Like, don't mention weight. Don't tell her, oh my God, you lost so much weight. Unfortunately, for people who are trying to lose weight, that's so reinforcing. It's just all that does is help the behavior to continue. So don't say the number out loud. Don't make a comment, or don't say, oh, you're looking so thin. You look great. Those kind of comments are negatively reinforcing, or they positively reinforce the eating disorder.
Yeah, I've sometimes the pediatricians, I have to say, no offense to pediatricians, but sometimes they're addressing weight issues in front of the
Yeah,
child, and it's not great.
right.
Not great.
What
You
we
know.
do is, if we have lots of pediatricians refer directly to our office for therapy, we will call the pediatrician first when we're looking for medical clearance or a medical appointment. We'll just say we suspect she might have an eating. We obviously have a release of information to speak to the doctor, but we suspect she may have an eating disorder. Please don't say anything about that and just report back to us, and let's collaborate on how best to handle it. So we're very involved with pediatricians, nutritionists, psychiatrists, neurologists, whatever collaterals, the school counselors, whatever collaterals the client has, so that we have a good treatment team, and we talk about having a unified approach. Because if a doctor goes, oh, she gains a little weight, you should cut out sugar, or you should stop eating bread. No, please don't stop eating bread. There's a psychological
Right.
reason, probably. Maybe there's a medical reason. You rule that out. There's probably a psychological reason. And let's see if we can explore that before you say anything to a kid. And we work with the parents too on when parents tell me, oh, well, we only eat non-fat foods in my house. Why? Why would you only eat non-fat foods, right? So non-fat foods equal foods with chemicals in them to make them non-fat. Why not just eat whole foods?
Regular whole
Why not eat
foods,
whole
right? Like we
foods?
did years
Yeah.
ago.
And what
Exactly.
is that about, right? Is that about you wanting to, what you think you're watching your calories or your weight? We also have a no calorie, no carb combos. We don't allow clients in eating disorder therapy or their parents to talk about calories or say the word fattening. There's no such thing as fattening, right? A piece of candy is not fattening. A chocolate cake is not fattening. If you eat the whole cake, you might gain weight, but there's nothing inherently bad about any food. It has to do with how much you're eating, when you're eating it, and why you're eating it.
And why you're eating it,
Why?
right?
Am I eating it? So I'm allowed to eat cake because it tastes good, right? How much of it am I eating? And am I eating it compulsively because it tastes good and it soothes me, and maybe it calms my central nervous system and it makes me relaxed? All right. Well, we don't want you to use food for relaxation all the time. You need to have other skills, other tools for relaxation, right? It would be like drinking 3 glasses of wine because it calms me. Well, that could become compulsive and addictive, right? And food the same way. So they're very complicated psychological, emotional, medical disorders. And we really help clients work on every level if you have an identified and diagnosed eating disorder.
Are you seeing? Is there a certain age bracket where you see more of it come out, like, or the starting of an eating
Yeah,
disorder?
that's a great question. So when I started as a therapist 30 years ago, anorexia was only diagnosable at age 18 and up. So you couldn't even have it, was a new diagnosis, and you couldn't even have it if you were a kid. Now we see 6-year-olds with restrictive eating. Yeah.
Wow.
So obviously that's family therapy. We're, the parents are the ones buying the food and putting it in front of the kid. Yeah. So every year we sort of notice a shift lower and lower. They're really young now.
Six
Oh
years
yeah.
old.
Yeah.
Oh, that's sad.
Well, there's something called
That's sad.
ARFID too. I don't know if you're familiar with ARFID. It's avoidant restrictive food intake disorder. It's an eating disorder that now is made it into the DSM manual, so it's diagnosable. It's not related to body shape or weight. It's more related to texture or rigidity in thinking. So like the kid that I told you that will only eat white things, he has ARFID. So he just restricts certain food types, not related to his body shape.
I had also read one time, and I don't know if it's true, that some certain kids with learning disabilities sometimes have a textural problem or an issue with food.
Yeah.
That can, is that true?
Yeah. There's a lot of disorders that come hand in hand. Yeah, there's people that don't have learning disabilities that have issues with textures of food, right? And so
Right.
the only known treatment for that is exposure. So, like kids with ARFID, the little kid that won't eat anything green, then basically how we start is we show him a picture of peas and broccoli because that's what his mom wanted him to eat. Then we show him a picture of another little kid eating broccoli and he's all happy. Then we make the mom bring in peas and the mom will eat peas and broccoli. And then we put the peas in front of him. Then him and the therapist will eat one pea together. So there's exposure that's incremental over time. And that's the only way to manage it. You can't talk about it. You have to do it. And it's not a fun procedure a lot of the times because the kid's not just sitting there quietly. Often you're having a little meltdown or an emotional outburst, and we have to manage that at the same time.
Is the reason why you don't talk about it because it's more control on their part?
Well, we do talk about it. We can't only talk about it. We also have to do it.
Right.
So we do
Okay.
talk about it and expose. We do explain it. Hey, we're gonna show you a picture of a little boy eating a pea right now. We're not just gonna be like, here you go. We don't want to freak people out or make them uncomfortable. We do talk about how the exposure procedure works. That works for anorexia as well. There's something called family-based therapy. I'm not sure if you heard of that, FBT. And we refer a lot of people out for FBT. I'm trained in it. We're not currently doing it in our office, but basically anybody 18 or under, the parents sit at the table with the child and serve and plate the food and serve it to them and sit there until it's completed. And the child has no say in what's in front of them. And that's an exposure therapy designed for anorexia or restrictive eating disorders.
That, Dana, that's what you call being raised in an Italian household, and that's what happened to you from day one at the table, that you didn't get up until your plate was finished. I remember my mother setting a timer,
Yeah.
actually.
Oh,
We couldn't, yeah.
interesting.
And it's
Yeah,
amazing.
interesting.
Yeah.
Yeah.
And it wouldn't be approved right now, but yes. Yeah, we couldn't move until our plate was cleaned, which probably ended up causing a whole other host of issues. But
Well, we want it to be managed in an appropriate way and make sure that it's not too much food or too little food and that it's the right amount of nourishment for that person's body type. So it is individualized. It's not just like, here, eat this lasagna till it's done kind of a thing. It is portion controlled and it's managed by the parents.
so how many patients do you see in a day, Dana?
Me personally, I don't see anymore, actually. I'm really just doing things like this, marketing, networking, running workshops, and I supervise the supervisors on our team, and then I supervise some of the therapists as well. So I have a few like former clients that I've been seeing for years off and on. I'll see them. I don't take new clients anymore. It's just the way that I'm building and growing the practice. It's better served for me to help the other clinicians as well. And after 30 years, it's my time to not do it anymore. So, but I love doing things like this, going out in the community and talking about the work that we do and, really helping our whole team administratively and clinically grow and make sure we're serving the clients well.
I was talking to Christopher about it before we hopped on the podcast, and therapists in general, they don't advertise. Like we're gonna take these clips, we're gonna clip them up and put them out on social media with your permission. But it's nice to know, or somebody sees a clip and you're speaking, and it's like, wow, this sounds like it could be an issue with so and so. Let me call and get some help.
Yeah.
I think it's important.
Yeah, definitely. I do a lot of workshops out in the community. I do trainings. I work with NASW, National Association of Social Workers, to elevate the practice, to bring more services to clients, and to help practitioners really grow their practice and understand, how to have a healthy practice, how to help clients, especially with eating disorders. It's a very niche field. We have 4 eating disorder therapists on our team. And that's who sees clients with eating disorders. It's niche. It's like going to an orthodontist. They're dentists, but they have a specialty in orthodontics. So an eating disorder therapist should be somebody who has experience working at every level of care with eating disorders. It's a very particular niche because it's medical psychological.
Right, it's both. And I also think it's important for people because it is scary to make that phone call and ask for
Yeah.
help. And I think it's important to be able to see somebody like you, right? You're not scary.
That's
Wow,
good.
she's great. I can talk to
Yeah.
her. And it makes it easier to make that phone call,
Yeah, good. Yeah.
because they feel comfortable.
I'm glad to hear that. Our whole job is to help people identify what opportunities they have for growth and change and to help them get there. We're in the business of
Right, which is
partnering.
so
We feel
important.
like we're partners with our clients. We want you to feel like it's a collaborative process. We can't make you do anything. We can just help you see what's possible and help you get there.
Right, right. No, it's so
Yeah.
important. I mean, I hope this isn't your last podcast with us
Oh,
because I'd
good.
have you on all the
Great.
time. Because there's so many things to talk
Yeah.
about.
Well, it's my pleasure to do
So
it.
Dan, where can
Thank
people find you?
Say that again.
Where can people find you? Website wise,
Awesome.
social media
Yeah,
wise?
thanks for asking. Well, our phone number is 862-200-7729. We do have a full-time client services manager named Alexis. She answers the phone. She'll help you understand what services are out there, what would be appropriate for you or your child. And then our website is really the best place. It's www.mindsoother. So it's MINDSOOTHER.com. And that's up to date with all our services. And clients can just click a link and schedule a phone call with us. And we're happy to chat. Alexis is on the phone all day with people, helping them, just listening to them and helping them understand what's possible for their care. And so that would be the best way to reach out to us.
And we
Awesome.
can also put Danna's information on the podcast, right, Chris?
Absolutely. Yep.
Nice.
Right on YouTube.
Yeah, that'd be great.
Yeah. We'll share all that information. And if any of your other therapists want to come on and do a podcast,
Yeah.
we would love it.
Okay, great. I
think it's important for everybody, an informal introduction
Yeah.
to the world.
No, that'd be wonderful. I have a few therapists that love doing it. So, yeah, I will speak to them about it for sure.
Tess being
Awesome.
one, correct?
Yes, Tessa. She's awesome.
Yeah, let's have Tessa on
She's
next.
been,
That'd be
she's
great.
wonderful. She's been with the company almost 10 years. Yeah, she's really great. Number two, she's our director. She does a lot of the clinical supervision for the team. And she's actually certified in EMDR. I don't know if you're familiar with that, but that would be something really interesting to talk to her about.
Oh, sure. Absolutely. We'll schedule that with Tessa.
Great.
Okay.
Yeah.
Dana, thank you so much for joining us today. I
Thank you,
appreciate it. I know
guys.
you're incredibly busy.
Thank you for the opportunity. Stay well.
Thank you. You too.
Thank
We'll talk soon. Bye-bye.